on the Compliance Guy Monday Roundtable. I'm joined by some of my very favorite people, Scott Kraft, David Duhame, Joe Rivet, Stephanie Howard, and Jordan Johnson. And let me just be clear, that list was in no specific order. I just rattled off names based on who I saw. So it doesn't mean I like one of you more than I like the other. I like you all the same. You guys are fantastic. So anyways, with that said, it is the 18th of May, 2026, and we have a fantastic show in store for you today. I actually want to start with Joe because I want to save my topic for a little bit later on. So Joe, you brought something up in an email exchange with us regarding a topic that I thought was really interesting. And I want to go ahead and start there. So if you kick us off, we'll get rolling.
Sure. So it's interesting as we work with clients that are in prepayment reviews and other types of audits that are occurring with these health plans, what I'm starting to see is almost a 1-2 punch is what I'll call it. Client is in a prepayment review. They're going through this process many, many months. Now the same claims are starting to cycle through a quality review, which frankly, the plans have a right to do. So we're reproducing the same claims, but now to a different department. Whether those departments talk to each other, who knows? But what's interesting with these quality reviews is there really no substance authority in them. It's really based on opinion, which is problematic. If you're doing a quality review, it needs to be based on medical policy, clinical guidelines that are well published. The ones that I'm seeing are completely absent that. At best, it looks like they may be AI generated letters because there is some allusion to a scholarly article, but it doesn't cite it. I had to go hunting for it. I was able to find the exact one that they had. So they have poor citation at best. So it's going to be interesting to see how these come about. I don't know if this is a new thing that's happening, but it's certainly something that I found more recently. And I do think it's a problem. I mean, if you have somebody in a prepayment review, let it run its course. Why are we now layering on another process of a quality review? Pick one and go with it. I don't know. That's just my opinion.
It's really interesting. I actually have a client in Pennsylvania who was sent a letter by Optum because they administer one of the VA programs indicating that there was a quality issue. And as a result, they were halting any and all referrals for new patients, and they were prohibiting patients that had been receiving care from continuing care until the issue was resolved, right? So now you're talking, and I want to be very careful. I'm not going to mention the specialty or anything like that. But now what you're doing is, it's already hard enough to get veterans the quality care that they deserve, right? Now you're telling them that one of the best institutes for this type of service is on a no referral from the VA list, even though it's an allegation that was made. It's not been vetted. It's not been confirmed or refuted. It's just out there. And on top of that, you're preventing continuity of care for patients that are already in clinical trials. I can't make this stuff up. We have patients that are in clinical trials. We have patients that are undergoing multiple levels of procedures, including injections and different types of treatments. And they were just cut off and they have no place else to go. Now, really interesting, because one of my favorite white collar criminal defense attorneys to work with, Andrew Feldman, got involved in this case. And Andrew went directly to Optum UHC and said, what the heck is going on here? And it took about a week, maybe a little bit less, for them to say, hey, this case has been investigated. It's been resolved. There's no quality of care issues. We've closed the case on our end. End of it, right? So you think VA still has not lifted their ban on new patient referrals or allowing patients who are established to continue their care. So to your point, Joe, you're already punishing an organization by putting them onto a prepayment review. You're disrupting their revenue cycle, which is probably wreaking all kinds of havoc on the practice's ability to make payroll, the ability to purchase new supplies, to get a new piece of equipment, whatever it may be. And on top of that, now you're throwing into the mix a quality review without defining what good cause is.
Exactly.
I mean, what are we doing?
So interesting fact.
Yeah.
Neither of I have shared, details. My client also cares for veterans, so I don't know what's happening. I really don't. Well documented. I suspect will prevail in the quality review, just as we did in this prepayment review, which we got off of. But yeah, it's terrible. I don't know if this is a new method, new tactic, new vendor. I don't know what's happening, but it's not right. So.
No, it's definitely not right. All right, let me go around the horn, because again, we have folks outside of Scott and David, who work directly with me on a daily basis. Stephanie, Jordan, you have some independent clients as well, and you're kind of going through probably some of the same things that Joe and I are talking about, or maybe you're hearing something about, from some of the groups that you're working with, that there's a potential of, this pending investigation into a quality issue. Stephanie?
So for me, I haven't necessarily seen it come about where it's framed to my clients as a quality review of the work being done. But one thing that is interesting to me, and Joe, you touched on this a little bit as far as how they're identifying these different cases and, the, AI scripted letter, things like that. It seems to me with the cases that I have going on that they're highlighted because of the dollar amount. So somebody internally is saying, "Oh, look at this service. We are paying all of this money." But then if you look to the payer policies, and honestly, Blue Cross Blue Shield is pretty bad about this. They don't always have a policy for most of the services. It always depends on the state, the region you're working with. And in that situation, I think I mentioned on the last roundtable, I had a client on hold with an Anthem plan, and they're quoting Encoder Pro, which is a mix of all different things, lay terms, CMS policy. Nothing's being cited as far as, what the truth is, what the source is. It's all based on a feeling. They don't want to pay for it. They think they shouldn't pay for it, but at the end of the day, they don't actually have a policy. So, Joe, that was interesting too when you said they were citing a scholarly article. That to me is hilarious, because that doesn't matter.
It's interesting that you mentioned feelings stuff, because this was a very subjective letter of really just presumptions and feelings, and I've never seen anything like it. I'm kind of astonished, frankly. I mean,
yeah. Before I go to you, Jordan, I just want to say one thing. I talk a lot of times on this podcast, and I blog about how critical it is to create a circle of trusted advisors, people who you can engage with on a regular basis to, provide you with insights and guidance and what they're seeing, how they're handling things. I can't stress this enough. These 5 individuals that are here on this podcast with me are part of about, 10 to 15 people who I consider incredibly trusted resources and valuable resources for a reason. And if you're not following them on LinkedIn, if you're not engaging with these folks, on a regular basis, you're missing out on an opportunity to stay abreast of what's going on in the industry and to maximize your insight into what's really going on a daily basis, because I know not all of you that are working at medical practices, at hospitals, at surgery centers, at suppliers have the time and resources to be able to go and do a lot of this independent research and investigation. This is stuff that this panel does, and we blog about it incessantly, and we talk about these things, and we put it out there. So if you're not following these great folks, please make sure you do. All right, Jordan, sorry, I did a plug, obviously not about me, but for the great people that are on this this panel. So jump in, my friend, take it away.
You bring up a great point. I think right now the documentation, all the utilization management companies, the documentation scrutiny, all this stuff that's happening under the concept of quality review. I think it's evolved beyond just a peer review or accreditation activities. Now they're getting into what's clinically appropriate, and so we saw a complete change of new CPT codes January 1st, which means everything is essentially being denied based on subjectiveness, like you said, or they'll quote a peer-reviewed journal from 2015 that's been out of date. Yet our clinical practices haven't changed at all, but now everything's being denied, whether it's failure to meet, defined medical necessity criteria, retrospective reinterpretation. Their AI, Steffi mentioned the AI algorithm, edit-based denials, frequency and utilization triggers. Again, we're treating the same number of fractions in oncology, same number of infusion treatments. Nothing's changed. There's no pathway deviation, but it's almost like this reinvention of how can I deny it, and it's no longer based on really anything that's authoritative. It's a personal assumption, or like you said, a feeling. And that it's very concerning, because we also got told by and whatever. I mean, it's public knowledge. United Healthcare basically said, "Hey, we denied it on the first time, but if you guys will just appeal it, we have 100% approval after appeal." That makes zero sense to me. Then why are we? Again, it's something that's put a lot of people at risk. It's put physicians and their time and their practices at risk. It's put staff at risk, and more importantly, I mean, then patients start getting bills and getting letters, and it's a problem. And it's interesting. This, for the first 5 months, this is rapidly becoming an issue.
Yeah, David, let me come to you for a minute. And I want to ask you a couple of questions, obviously, because you worked for the Empire for a period of time, and look, you were in a senior leadership position, and I've come to really know you well over the last year, and get to understand who you are as a person, as a professional, your level of integrity. I mean, how did you deal with these things when you were at the UPIC? How did you give guidance to your staff, your subordinates, middle managers who were responsible for putting these investigations together, conducting these audits as part of that, and ensuring that they were relying on authoritative published guidance as opposed to just kind of running the gambit with stuff?
So I mean, to hear somebody is basing on feeling is, to everybody agrees, it's very problematic, because obviously the side that I was in, this is potential where something going to go to a criminal case. You have to be supported by a law, by authority, by things that can be documented to show exactly what they're doing. And I used to have this conversation with investigators. They'd be like, "Well, I feel like there's something happening." I'm like, unless you can show me something happening, you can have all the feelings in the world, but they don't count towards getting to an end game. And we were even so specific, especially if you were doing a post pay, we made sure, because, and Jordan, you brought it up, something changed from last year. So literally half our review may be based on this year's coding and policy, where this half is going to be based on the new one. And that potentially could even change your outcome. It could be last year it wasn't, it was bad, but halfway through the review, it's now allowed. So I mean, you have to take all those into account, because if you're going to go to the point of demanding someone's money back, disrupting their practice, and being able to support that later, because from my perspective too, I got evaluated as a contractor. If I had these issues that come up and they're wrong, that's going to negatively impact my contract evaluation. So I was more concerned with making sure we had it right. And also, when you go through those other levels of appeals, we were evaluating how well we were doing. If we were getting beat a lot, we would take a step back and say, okay, we need to reevaluate whether or not we're following the policy correctly or our interpretations are right, because we're not gaining anything. So it becomes, again, problematic to the providers. They're going through the repeat process. And ultimately, if we're doing it wrong on the front end, we're becoming more of a problem in the system rather than something that's designed to help the system be compliant.
Scott, you are the person within the department that we work in, right, which is strategic litigation support and regulatory affairs, which includes audits and education and all the things that we do for our clients. You primarily get to work with the larger health systems that we engage with. What are they sharing with you? What are you seeing? I know you just came back from being on site with one of our large health system clients last week in are they? Yeah, they're in the Northeast. So
Mid-Atlantic,
well,
I think,
mid-Atlantic
depends on how
states, you're
you
right.
interpret geography.
Yeah, they're right
Northeast
on
enough,
that
right?
border, right? Because
Pretty
where
much,
you
yeah.
where you fly into, they're kind of northeast, and then you drive and you become mid-Atlantic. So, anyways, as you continue to remind me that I need to brush up on my geography from time to time, what are some of the things that you're hearing, you're seeing from a pain point perspective?
I mean, I think we're seeing a bump up in additional documentation requests. We're seeing a bump up in, letters concerning utilization. We're seeing a lot of different requests, different investigations, different types of reviews of different things that are being billed. So modifier 25. And what I think is frustrating to me, just between what I'm seeing in this conversation, is that I hate to sound obvious, right? But compliance is hard. These policies that providers operate under are hard to follow. They change regularly. And so when we start to help our clients get systems in place for quality, systems in place to make sure that we're doing the right thing, and the goalposts start to move, it's very frustrating. And I think some of the stories that we've already heard on this podcast, and I mean, when I see boosts in additional documentation requests, I mean, that's sort of tier one of what we're talking about. There's a cost to it, and you have to do this internal investigative work to determine whether or not you're doing something right. But when you start to layer a quality review on top of that, or you start to layer on prepayment review on top of that, Sean, you and I have seen all manner of investigations into like behavioral health services related to these things. It has a very chilling effect on our clients, on the business of medicine to begin with, to realize how easy it is for an insurance company, for an investigator to seriously impact or impede your ability to do business, particularly when they're doing it in this sort of extra interpretation or extra legal or whatever phrase you want to use, where they're putting things in front of you that aren't necessarily parts of written policies, or they're going on feelings, right? And one of the fears that I have, and this is a little bit of speculation on my part, is that AI, in addition to the many good things it does, it's going to usher in this like age of incompetence in a way where, if I want to investigate somebody in a non-AI world, I've got to do a certain amount of due diligence. Like, I've got to do my homework to be able to go out and investigate whatever I'm going to investigate. But if I can just start querying an AI tool, and maybe my citations aren't quite right, maybe what I'm doing is one review on top of the other. I think some of my fear is it makes it easier to drive these investigations where the foundation isn't necessarily there, and it becomes easier from an accountability perspective to be putting these investigations out into the universe, even though they may not be fully formed. And so I realize that's sort of a long answer, but I feel like a thing that we are all seeing right now is this increase in investigative probing kind of work And I wonder what's driving that. And it has a real impact on how services are provided in the real world of medicine, frankly.
Yeah, listen, I, I think this is a topic that we can, continue to go through, for an hour, and I think everyone has given some incredibly salient points on that and made at least listeners aware of what to pay attention to, what's transpiring, and the for me the takeaway is if you receive one of these letters, one of these notifications that you're under a prepayment review, you're under some kind of UPIC investigation, you're going through some type of audit, you're starting to see a slew of ADRs, additional documentation requests coming into your office for one or two specific types of services, you need to reach out to somebody who can engage on your behalf and try to uh, cut it off at the pass before this thing gets into a perpetual cycle and you can't find your way out of it, because these can be, as Joe will tell you, as David, Jordan, Stephanie, Scott, once you're in a prepayment review, you have no appeal rights. You are stuck in that prepayment review until they decide they want to remove you from it. And there are things that you can do, but again, it takes somebody who understands how to navigate that system appropriately to be able to, ease the burden up for you. Go ahead, Scott. What were you going to say?
Yeah, no, one thing I was going to add to that, I think you made a very good point. And even in this investigative requirement, right? I'll tell you the same thing your trainer will tell you at the gym. You got to lock in and work on your core.
There you
So
go.
these services that you provide, even if you're not under investigation, you kind of know what the bread and butter of your practice mix is. Lock in, right? Like you want to review those things and you want to feel like you are on very solid ground from a compliance perspective, because
Yep.
you're, if you haven't seen this activity yet, you're probably going to start to see it pretty soon.
Yeah. So as you were talking, you brought up behavioral health, and behavioral health is an interesting challenge. And I'm going to have Sandra Kunze on the podcast coming up here, I believe later this week, and we're going to be talking about behavioral health. And she's somebody who I have a tremendous amount of respect for. But it came up through our email chain that it appears, Stephanie, that there are some providers who are wanting to charge patients for the extra work that they believe they are doing, that they're not being compensated for by the carriers, by the payers. And Joe said, well, this sounds a lot like the G2211, which is that add-on code to the evaluation and management services, for which Terry Fletcher and I, on our hashtag Terry Tuesday a week ago, did a whole segment on the truth about the G2211 and how it should be utilized, when it should be utilized, when it shouldn't be utilized. And then we co-authored a paper that we published last Thursday on it. But you're seeing this in behavioral health. And I want to give you an opportunity to kind of talk about and share with the listeners what it is that you're seeing, what your clients are telling you, how they're handling it, and what your guidance back to them is. Because I think they're setting themselves up for some potential problems if they don't curb that behavior pretty quickly.
Yeah, and I want to preface this by just saying, in my experience working with behavioral health, especially when it's smaller practices and maybe just one practitioner or one physician, it's for some reason they have this disconnect where they don't have as much information being funneled in related to compliance. And I don't know if it's because them among their peers, they don't have a lot of resources out there. That's actually great that Sonda's going to be on this week, because she's excellent in the behavioral health space. But one of the things that I'm finding is the practices are always looking at what they can do from a reimbursement perspective, especially if they're a private practice and they're smaller and they want to make sure that they have enough revenue coming in for, essentially, it makes sense, every minute that they are spending. But one of the things that's been interesting is that over the past month or so, I've had multiple questions related to psychotherapy and essentially people wanting to extend beyond the 60 minutes. So the highest level psychotherapy code represents 60 or more minutes. So whether you do 90 or you do 60, you still report the same CPT code. And it even got to the point where I actually had a patient who found one of my podcast episodes on YouTube email me and ask if what their practitioner was doing was okay, because they felt they needed the extra time, but they also didn't think that they should have to be paying. So at the end of the day, it has me thinking about, how many other providers, how many other specialties are looking at the decreased revenue, the increased administrative costs, everything we talk about on that side with, the battles with the payers just to get a claim reimbursed. It makes me worry because they're trying to be very creative in the ways that they're doing that. And with this psychotherapy situation, what I've been hearing is that they're wanting to bill out the CPT code for the 60 minutes, but then either have the patient sign a form saying they'll pay self pay or just bill them self pay for however much additional time. I don't actually know like dollar amounts or how they're coming to that conclusion and what they feel is compensating beyond the 60. But this is a real issue when patients are talking about it. Some of my members own billing companies and they have their clients asking them what they can do. One even asked if they could separate services throughout the day, maybe like have 2 hours in between or something. And my thought there is how are the patients going to handle that if you got to
I
sit and
can't
wait 2 hours for
I
your
can't
next
imagine.
therapy
Well,
session?
I mean, what do you talk about for like 4 hours of therapy? Like, I don't like what. I don't,
So Joe, I'm going to come to you for a second here, and I'm just going to throw this out. Um, Sounds like a really bad business model.
I would agree. Yeah.
Legally, and again, I'm just asking you for your opinion, not your legal guidance or things like that. But from a legal consideration, this really to me sounds like it could fit into an FCA category if a prosecutor wanted to just push the pencil a little bit, right? Not much, just a little bit. Because, it certainly sounds like reckless disregard. It certainly sounds like there's knowledge of what they're doing and the fact that the claim could potentially be false. There's also the possibility of a reverse False Claims Act violation because they go back and they look at what was the mindset at the date that these claims were actually being filed. And this to me kind of seems like it could potentially be setting up these practices for a False Claims Act fight.
I think it's possible. I would say certainly you might have a contract violation for those that you're in network with, because there are almost all contracts are going to have a hold harmless provision. So, to Stephanie's point, if you're billing for a service that's a billable service, you appropriately bill for those. Obviously, you document them, so on and so forth. But to incur additional charges and shift that over to patient liability, certainly inappropriate. And I would be hard pressed to say that it would definitely be a contract violation at minimum. So you would risk losing your contract. So you're going to have a whole other problem. Those are just kind of my thoughts on that. But
there's one other thing that I just thought of too, and I haven't gotten this question as much recently, but what you were saying, Joe, with the contract violation, I had a lot of people reaching out at one point, typically larger organizations. They'd have a physician who had a friend who was doing this thing, and they wanted to start charging a monthly fee to provide the services that are already required that they provide based on their contract. So they were going to give them priority scheduling. They were going to do something as far as telehealth goes, but the problem was the plan still included them billing telehealth to that payer and them doing all of these administrative tasks that they're required to do anyways
I mean, it
as a
sounds like
medical
concierge
practice.
medicine.
They were trying to mix it. Yes.
Yeah.
Yeah.
but it's what they're doing is discriminative practices, which is also, there's also a prohibition in those contracts as well. So you're breaching that contract multiple different ways.
All right. So 2 topics down. Let's jump to Jordan. Jordan, you sent a really interesting topic, and I started taking a look at it, and I thought, with everything that's going on in program integrity, it only makes sense that we're now seeing CMS reclassify or restructure the way that they are actually paying for services. So take us through what you're seeing, what you're hearing, and really what's on the horizon from a payment integrity standpoint with CMS.
Oh, absolutely. I mean, I think right now we're at an interesting crossroads, and we'll see. Obviously, the proposed rule will come out in June, but we're starting to really see things. And when we look at the MPFS side and the freestanding kind of side, how the physicians are paid, it's always been based on, as much as we want to say it's value, it's always been based on volume. And a lot of that's been driven by the work RVU. And the work RVU, in many cases moving forward, is no longer becoming a sustainable rate. And what's driven a lot of that is a lot of your specialists have now become hospital employees. So when we look at radiology, report was released last week that 82% of radiologists are now employed by an institution, where 85% ish of radoncs now employed by the institution, and a lot of your other specialties are employed by the institution. So what happens is that work RVU on the professional component alone oftentimes does not make those physicians whole. So then what they want is compensation, whether it be from a medical directorship or however it's arranged from that hospital side, that technical revenue. The hospital doesn't want to give that up now because now they're being pinched on their reimbursements, what the hospital gets paid. And so it's really kind of exploiting the gap that's been there of how do we pay for the physician services to get outside of this RVU based model. And I think CMS is looking at some of this. CMMI looked at it for years with several failed attempts and failed models at case rates. And I don't think case rates are necessarily the answer, because I think you also have to look where case rates often fail is they forget to look at what is the total cost to deliver that care. It's not just the CPT code, it's all the other things that are involved. And so I think as CMS and some of the employer-based models are starting to look at this to say, okay, we can pick certain areas. I mean, CMS did the hip and the knee replacement bundle that worked really, really well. I think that's applicable to other service lines, but I think they're getting to that point to where they realize that the RVU model just is not a correct, as far as accounting goes, doesn't account for much of the work that the physician does, and also has a huge impact on your fully freestanding facilities that don't have the financial resources that the OPPS hospital side have. And so how do you maintain that? As they've pushed more towards site neutrality, that's kind of what's exposing this is, okay, the RVU model may not be the best approach. And for years, we've had the AMA and CPT codes, And there's always those camps of arguments is just pay based on ICD-10 versus CPT code. There's lots of camps that go back and forth. I've said at several of the AMA meetings and different meetings, but I think now that pressure cooker is enough to where we can start to look at, entertaining some of these models to keep the physicians. And it's not about keeping the physicians happy; it's paying the physicians what they're doing the work for, and making sure they're compensated correctly, without breaking the system and without it just being based on volume.
It's interesting that you bring up value-based care, because one of the things that I've said, dating all the way back to when they first started talking about VBC, value-based care, right, is that you can't determine value until you understand the volume of services that are involved, because you have to have some kind of a baseline. You have to have some kind of a foundation in which to be able to build upon. For as faulty as the RVU payment mechanism is, right? The argument of, well, why aren't we just paying based on the ICD code becomes sort of an enigma for me, right? Because when we think about claims processing, the value of a claim is paid based upon the work relative value unit, the practice value, the malpractice value, the gypsies that are added in, multiplied by, the conversion factor, et cetera, right? So it's a mathematical equation that they use to figure out the work, the practice, the malpractice. Is it imperfect? Yes. But it at least gives us some kind of structure to be able to see how services are valued, and it could go before the resource update committee once a year, and they can have a discussion about it. Sometimes they throw shoes at each other. If you've been to one of those RUC meetings, Scott, I don't know if you were there with me or if it was Paul Spencer, but somebody threw a shoe at the meeting in Chicago several years back.
I wasn't at that one. No, I wasn't.
Yeah, it reminded me of the George Bush press conference when somebody threw a shoe at President Bush. But anyways, I digress. You can't pay just simply based on the ICD code, because the ICD only tells us why the service was performed. It doesn't tell us what services were performed. It doesn't tell us how many units of the service were performed. It only establishes the medical necessity of the service, right? The medical appropriateness, the reasonableness is what's driven by that diagnosis code. So, I think when, the shift happened from another horrible term, which was called usual, customary, and reasonable, because nobody ever knew how the heck that was calculated, right? I mean, what is UCR based on? I mean, what's usual? What's customary? What's reasonable? I mean, it's subjective. At least we moved to a mathematical equation that was based on something. I don't know, David, you spent enough time working in the government and looking at RVUs and how these things are calculated and how it applies to payment methodologies. I mean, any thoughts?
Well, David, before you jump in, I was just going to add, where a lot of, Stephanie, your practices are going to feel, Scott, your practices are going to feel, is what's driving this too was that efficiency adjustment, right? So anybody that's doing procedures is fixing to feel that for procedural service, that 2.5% dip that they're taking because they feel like people are just going to get more efficient, which is not true. But who it helps is the non-procedural, which is the primary cares, which we all agree that they need help. But that's really what's kind of driving that forward even more, to look at that redesign for expense methodology, and how things are reimbursed. And I think that's going to be, it was kind of far-fetched before, but now that efficiency factor, I mean, it's written in stone, it's happening this year. I think that's when the practices, when that first 2.5% happens, that's when people are really going to push back and say, hey, this doesn't account for things. So David, go ahead, jump in, man.
Thanks. I mean, I think this is the design of everything. And when they build programs like this, everything starts with a good intention. They try to come up with something they think is going to help. And ultimately, what's up happening in the end is you get these things, as you guys have discussed, this dissatisfaction with it. Somebody feels like they're not getting paid. Somebody feels like something's not happening. And potentially, from my standpoint, is this is where the doctors start changing behavior. This is where they try to find something because they feel like they're being marginalized. They feel like something's not being paid. So this potentially creates some of those challenges. And even talking with CMS themselves, you know, they've done these policy changes and then realizes there was a negative impact to that. So I like the idea of what they're trying to do, but usually it ends up in somebody's not happy somewhere. You can't make everybody happy, but when you start having a broader dissatisfaction, that's when you start having more problems with it. And that's ultimately what drives the behavior, is because they're feeling like I'm not getting something, or we're being marginalized, so I have to do something else. So.
Yep. Scott, I see you chomping at the bit. I saw you doing the hand jive from Greece. You want to jump in and?
No, I was just. It's like my arms were.
All right, so you were just getting your workout in. I got you.
Yeah.
Let him out of the cage. Let him out of the cage.
All right.
Get, you know, when I sit, my watch doesn't give me credit for exercise. So I have to move my arms a little bit. It's
All right.
very,
All right, so then I'll take us into our last topic of the day, and this is one that is incredibly personal to me because of the number of administrative law judge hearings that I've already done so far this year. I've literally done where I was leading and conducting them, and Scott, you've been on these. I've done 8 so far, and I've engaged with other attorneys in probably 4 or 6 other ALJ hearings. And the ALJ hearings right now, for me, 99% of them are based on the misinterpretation or the misapplication, not misinterpretation, misapplication of local coverage determinations. And you know, for me, I published an article about this today in anticipation of the podcast, and one of the things that I said in there was the rule should be the rule as written, not the rule as imagined. And what do I mean by that? Well, Medicare has an LCD process, right? For promulgating an LCD, that there is actually a process that they have to go through, and then there's a process for revising the language, for editing, for whatever it requires for the LCD. But when somebody at the Targeted Probe and Educate group is kind of making up rules as they go along that are not published, it's an imagination, right? You know, an LCD doesn't give a reviewer the right to create extra things that they want as a personal preference during a review, simply because in their mind they believe they should be looking at those things, and those things should play a role in making a determination on the medical necessity, the appropriateness, the reasonableness of the services. And that's not the case. And these ALJ hearings that we have been doing, and these have been on one specific thing so far, these 8, actually 9 so far. Collagen surgical dressings, LCD L33831. This is a policy that, for whatever reason, the Medicare administrative contractors and the QICs have decided to create some type of mathematical formula to make a determination based on the length, the width, the depth, as to whether or not the wound cover dressing, the primary collagen dressing, is big enough, or whether they should be using smaller 4x4s or 7x7s or whatever it is. The problem is there is absolutely nothing within the LCD that allows them to create a mathematical formula for making a determination as to what size primary dressing needs to be on a linear wound. And as a matter of fact, the actual verbiage in the LCD says it must be appropriate to the size of the wound. That's all it says, appropriate to the size. But they've decided to implement something that doesn't exist, which is called the 2-inch rule. Well, the 2-inch rule applies to a secondary dressing covering, which means that the island pad or the secondary covering, the gauze over that primary bandage, needs to be 2 inches bigger than the primary dressing. Anyways, we have gone through a number of these hearings now where we have prevailed in every single one of them, with the exception of one, which is now going to either be remanded to another judge or it's going to an appeal council review. And I'm 100% confident it will get overturned based on 8 prior de novo hearings, all ruling in our favor. And sort of what was given as a ruling decision by the judge kind of didn't really make a whole lot of sense, but that's another conversation for another day. But take what's going on with the LCDs and you can apply that universally to LCDs across the board, especially where you have an LCD in one region that allows for something and an LCD in another region that doesn't allow for it. LCDs that are based on the preference of the medical director or the CAC, but yet they are failing to take into consideration state law requirements for things like the frequency of urine drug testing, how many analytes have to be looked at. So the thing to keep in mind when you're talking about an LCD is this, and Joe, I'm going to come to you obviously as the legal scholar that's on the program here. One, an LCD is meant to create payment policy, not clinical judgment, not medical necessity. It is not a clinical policy. It is created to provide payment policy for services that are rendered. Second, an LCD is a sub-regulatory guidance document. Even though they have their promulgation process, it's not the same thing as a national coverage determination that has a public posting, a comment period, stakeholder involvement, all of those different things that puts a promulgated document into place as Medicare law. And third, LCDs are not binding. They don't have the binding effect of law. Now, I want to be careful in how I say this, because at the end of the day, you still have to adhere to the LCDs. You have to follow the requirements of the LCD, right? For frequency, for diagnoses that support medical necessity, for modalities that could be used, etc., site of service, all these different things. But at the end of the day, when there is an argument about coverage and it boils down to an LCD, it is often based on the fact that the LCD is not being adhered to. It's being misapplied by the reviewer, and they are substituting what is actually published documentation for their personal preferences. So I know I kind of opened my mouth and a whole lot of stuff just flew out, but Joe, I'm hoping you can kind of take what I said and make some sense of that for our listeners.
So I think a common theme here today is feelings. All that's out the window. I mean, it boils down to really what the law is, what the regulation is. When we get into LCDs, it's always interesting when you have one LCD in one jurisdiction and not in another. That can be very helpful from an appeal standpoint, because go to the references that they use to build out the LCD. But the bottom line is they need to follow the four corners of that LCD. They can't start putting in mathematical formulas that don't exist. I've seen that as well. With a different setting, but similar LCD situation where they oversimplified a process for the reviewers, and it simply doesn't exist. and I would challenge and fight those. I mean, that's all you can do. And whether you're a solo practitioner or you're one of the biggest payers in the country, there's due process. And I think a lot of times the small providers feel defeated. There's a process, and I would say go through that process. It does take time, but you got to get paid. And at some point there has to be, I don't know what word to use here, crackdown, reform, of how
Oversight.
oversight of how
Accountability.
these things are being executed, whether it's a prepayment process, LCD, et cetera, because it's getting a little too unilateral authority anointed by themselves. Somehow they're giving it to themselves. It doesn't exist. And so every day, Stephanie, David, Scott, all of us, we're fighting this on a daily basis.
Yep. David, I want to come back to you. It always seems like when there's something negative to talk about from a payment perspective, I come to you. But let me ask you this question, because again, as somebody who was the senior person at the Unified Program Integrity Contractor, when somebody like Joe Rivet, myself, Stephanie, Scott, Jordan, Andrew Feldman, whoever it may be, reached out to you and said, hey, listen, you guys opened an investigation against one of our clients. We are reading your findings, your determinations, your overpayment, recommendation for CMS, but your reviewer is citing things that were not in the LCD, that are not required. And they appear to be, to Joe's term, their personal feelings, their personal wants, their desires, whatever it is. How did you deal with those things? Because I know you had to get those calls on a regular basis, because I've called people who you and I both know who are senior people at the UPICs. And one of my favorite guys is in the Midwest. And, I've reached out to him and I've said, hey buddy, what's going on here? Yeah, please talk about this.
Well, I think that, this whole thing about feelings, I agree with you, Joe. This is creating an environment which I think is inherently dangerous, because you're starting to, LCD shouldn't be, let me convey my decision. It should actually be something that's designed around what's in the documentation. I do agree, because they create some of this, challenge between what is the hard and fast rule versus what is that. We had a very rigorous QC process. So one of the things, we had some of those phone calls. I've had my phone call with Andrew Feldman, is the fact that, we tried very hard not to get into these situations, because if we started having this ambiguity, then this is where we started getting into situations. And this was one of the things, and it was kind of it's the same thing I had with investigators. Investigators be like, oh, I feel like this is going on. I need you to prove it. I need you to show that you can actually back this up and validate it. And it was the same with the medical review. You can have all the feelings you want, but we don't work on feelings. We work on rules and guidelines and things that people either are violating or they're not violating. So we had some, but certainly not as many, because I think we were a little more self-aggressive on our own, because we didn't want to get into these situations. We didn't want to create some of this ambiguity, because like I said, if I started seeing I wasn't winning at the quick, I wasn't winning at the redetermination, that's not good. Also, from the world that I came from, you could get a congressional phone call. Somebody reaches out to their congressional person. Next, CMS is calling me to the carpet. So you wanted to minimize those, still be as effective as you can, but also minimize that. And it just really comes down to, what do the rules say? What are the guidelines? And, and I've had nurses that, when they did the review, they're like, well, I feel like that. I was like, you can't use feeling. And they would get overturned. And that was one of the, reasons why we didn't, or we would try to push that out. So.
And one thing real quick. So David, what I find interesting with some of what I'm going through, and recently, for example, with the laboratory, we still have the toxicology cases out there. And, everything from the UPIC level up, including at the ALJ hearing, all of those levels are completely ignoring what CMS has in black and white and still holding labs to certain standards. And, for me, what's not making sense is a lot of this is coming down to what they're saying is medical necessity. but then it leaves it all up to subjectivity. And even with the different wound care cases, the skin grafting, all of that, they'll list all of their different resources, which I think a lot of times are nonsense. It's just, maybe they took 3 words out of it, so they put it as a resource. But a lot of it's coming down to this very subjective stance on, for the other side to argue.
Well, and I think
Oh, go ahead.
no, I was gonna say, I think in terms of the, I've worked with Sean on the collagen cases, and I think, his sentiment that they're misapplying the LCD is almost like a kindness in a way. Like, it's not a terribly hard LCD to understand,
No.
and it's a followable LCD. It's an LCD that you can systematize the following and compliance with this LCD when you're providing the supply in a medically necessary way as outlined by their own policy. And so what I think we're seeing, going back to the subjectivity, is this moving of the goalpost, this introduction of additional factors that are not part of the LCD, are not in writing anywhere, but are being used as the foundation to deny payment, and then this placing of pre-bill, or this use of pre-bill as a, it almost feels like it's being used, to penalize compliance, right? To penalize the fact that compliance is happening in a way that they don't fundamentally agree with, and that to me is centering on a lot of this subjectivity and just, okay, we gave you something to follow and you're following it too well, so here are some other problems.
And I'll leave you all with this, and this is something that I'm getting ready to take to leadership at CMS. Actually, I've already sent my letters to leadership at CMS. What the MAC and the QI, well, take the QIC out of it. What the MAC has realized is that they are continuously losing at the ALJs, at least to me. I don't know how others who are going before the judges are prevailing. I hope they're making the same kind of arguments that we're making. I've shared those with Joe, and we've gone back and forth on really the arguments that we're making. And Joe and I are getting to work together on some of these ones that are coming down the pike. But what I have now seen, and to me, this is so unethical, because the MAC has realized, at least on my clients that have all prevailed at the ALJs, they have now put some of our clients under a prepayment review for these collagen dressings without good cause. Because if you've already lost at the ALJ, and the AdQuick has already asked for it to be remanded to another judge, and another judge, de novo, has come back and issued their own wholly favorable finding, and there's now 8 de novo findings that the MAC has gotten it all wrong. Going and doing retrospective reviews and then having, these things go to the ALJ and you lose, to David's point, potentially calling you to the carpet by CMS is a big problem. But if you don't deny them, and if you don't reopen for good cause, whatever good cause may be, and if you just out of the gate take every single one of these claims that's being filed and you put them under a prepayment review, well, the client now has no rights except now to cry foul to CMS and to show a level of unethical behavior, which is exactly what's happening here.
Well, and I would just add to that, given the cost of the good, it feels malicious because it creates an
absolutely is malicious. And you know what? I may take some heat for saying this, and I'm okay with that. But what this particular MAC is doing absolutely is malicious in my opinion, because there's no way they could explain in a logical, good faith way that we've just decided not to do any further retrospective reviews. We're just going to put everybody on a prepayment review, especially practices who have already gone through the administrative law judge process and have had the claims adjudicated in their favor. Explain to me where there's any good faith there. The problem is because they're a contractor to the Centers for Medicare or Medicaid Services. They get to hide behind CMS. They have deep pockets. And if you sue the MAC, Joe, who's going to represent them? The DOJ.
Yeah. This is out of control. These whole prepayments. They're really they're weaponizing them against the providers. I mean,
such a great term. Such a great term.
Weaponizing is the right term for sure.
Yeah. All right. Well, that takes us right to our 1 hour mark. We are going to call it a wrap for today. I want to thank Scott, David, Joe, Stephanie, and Jordan for joining us on this Monday Roundtable. I know the last one kind of fell through the cracks. That is my fault. I'm not going to tell you my personal business for why we couldn't be on, but that one was all on me. But we are back on track. We will be back in 2 weeks. I will be back tomorrow with Terry Fletcher and our brand new #Terry Tuesday episode. And then I'm looking forward to catching up with Sandra later this week. And I've got another special guest later this week who it's going to be a great conversation about government advocacy and outreach and really some of the cool things that this particular specialty society is doing with this attorney to ensure a level playing field for their members in that society. All right. Thanks for tuning in, logging on, and hanging out with us as always. As I said, we'll be back a little bit later this week. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.